Welcome to Inside Aesthetics, the world's leading podcast for injectors and cosmetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor based in Sydney, and I'm joined by my co-host and good friend David Segal, an entrepreneur and an aesthetic business mentor. Each episode of IA showcases unfiltered conversations with guests from around the world. In a sometimes disjointed industry, IA aims to help educate and connect our global community to raise the bar for both our businesses and our patients.
To further support and educate our listeners, we offer a range of additional resources under our IA Patreon subscription service. This caters for injectors and business owners of all levels and includes interactive live Zoom sessions, webinars, hints and tip videos, private chat groups, and exciting future content to come. To subscribe to IA Patreon, head to www.insideaesthetics.com/Patreon or click the link in our podcast description. You should seek medical advice before undergoing any treatment or procedure, and these podcasts do not replace a professional and bespoke consultation.
Wednesday, here we are again.
Wednesday podcast day.
Wednesday podcast. And what are we talking about today, Jake? Because, noses.
We've got the Nose King.
The Nose King.
We'll start with noses perhaps, but we're back to our old friend of aspiration, moving needles, the whole drama debate, shouting matches on Instagram.
All the topics that people stay very calm about online.
Yeah, exactly. There's no polarization or angry people at all. It's all very calm. So let's introduce Dr. Alexander Rivkin. How are you today?
Great. How are you guys?
We are
I
well.
hope you guys can hear me okay?
Yeah. You've got one of the best sound setups that we've come across. So this is good.
Good.
We do sometimes struggle. How was your day? Were you injecting all day? What was your day like today?
I like to give these days. A lot of my days, I like to give half the day to injecting and half the day to admin stuff because, at this point, there's papers, there's research, and just kind of there's Instagram as well. It eats up a chunk of my day. Unfortunately, I have to admit. So half the day injecting, half the day doing nonsense.
Nonsense. Well, whatever you're doing, it's working well. People will obviously know you probably through Instagram. That's how we've connected. And thank you for making the time to sort of come on the podcast and share your thoughts. But tell us about your background. You obviously started as a surgeon. So just tell us how it all started and then how you fell into injecting.
Yeah, it was a funny route, really. It's just, I started out as an otolaryngologist, and and then I just I got out of my training, which was, between me, you guys, and, your entire audience, not a pleasant experience. Some people, with some people it goes with their personality. With others, it didn't with me very much. And so after I got out of it, it was just when all this, these fillers and Botox first started to get FDA approved. And it seemed to me and I didn't particularly want to do ENT. That wasn't burning me up. But what was interesting was this possibility of a new field that was being created in front of my eyes, and it was so creative. You could make stuff up. Yeah. Which really in medicine, you're hard pressed to find instances where you can make stuff up. You'd hardly want a very creative, proctologist or, cardiologist. That would be not great. So that just presented itself. And I thought, gosh, this is completely new. This is so interesting to explore.
Yeah.
So,
and just to sort of orientate time. So you said these products are just being listed or approved by the FDA. So where were you in terms of what year is this in? Because we've had people on like Gene Carruthers and Michael Caine and obviously Arthur Swift, and sort of those people were sort of in the pioneering days. And it sounds like what you're describing is around that kind of time frame as well, or are we slightly after?
Yeah, 2000. It was 2003.
Okay, right. Okay.
So it was a little bit after the very first pioneering days.
Yep.
So those guys had done already their work, and it just came onto the market, but nobody really. But most people didn't know what to do with these things.
Yeah, yeah.
So,
and where were you situated, and sort of what was your practice looking like at that time? And the process of, I guess, moving your emphasis or the focus of your practice onto something that was still very, very new.
Are you trying to say, how did you con people to do this weird new creative thing that no one knew anything about?
Right. Well, I mean, but this is the thing about surgical. This is the thing about surgical residency, right? You're the one thing that the one very valuable thing. Well, it's not the only thing, but it is one, I think, quite valuable thing that you get out of surgical residency is a boundless sense of confidence, right? Because you could be dead wrong on, as a surgeon. What is this? What's the saying? Like, sometimes wrong, but never, never in doubt, right? And so I was never in doubt. I came out as doing ENT, and then this happened, and I thought, I can run a business. I know I have the instincts to be able to run a business because my mom. So we're from USSR.
Oh,
right?
okay.
We're from a land that no longer exists. We're from USSR, and my mom came. We came to the United States in 1975, and my mom started a skincare business, and so I've been around kind of aesthetics and beauty and business for a long time, as long as I can remember. So I knew I could run a business. I knew that this was very interesting to me, and it was obvious. I don't know. It was obvious. It was obvious that this was the thing to go.
Yeah.
So, and I knew that nobody else. And I sensed the niche because nobody else was doing just that, and I knew that I could. And also, which was interesting. Nobody else understood the internet either. Nobody else understood Google.
Yeah.
No doctor. This is 2003. The Stone Ages, right? By internet time, nobody had a decent website. Like everybody's website looked horrible. It looked terrible. So I think, I thought this was like, I could do this. This is possible.
So I was saying one of the common things that we've had with our pioneers, Gene and John Joseph, on our last podcast, all of their colleagues and family even said they're mental, that they shouldn't be doing this and you should stick to being a surgeon. So did you have the same kind of experience?
Yeah, I did. But I don't know. I just kind of discounted colleagues. I just kind of, they didn't exist for me really. It was me. And then there was a population of people who I was absolutely dead sure were going to come to this like it was catnip.
Yeah. And obviously there was no one really training anyone on how to do these procedures back then because no one knew anything about anything. So what was your sort of approach to treating patients? Like what kind of procedures? I guess toxins in the upper face and nasolabial folds with filler seems to be what most people did in that period. So is that what you were doing? And where were you gathering your knowledge information that was guiding the way that you would approach and treat patients?
I was leveraging whatever knowledge I could find, whatever piece of information I could get. Working with the companies, Allergan in particular, was helpful in terms of getting me information and trying to orient me into the right direction. Going to conferences as much as I could to try to listen to how people were doing this and where people were going and what ideas I could glean, and then I was just making it up. I was just making shit up daily. I was just like, this sounds like, and again, I was like, I've done neck dissections and laryngectomies. Like, what could go wrong, right? I can handle anything, any issues that can happen. This sounds like it would work. I'll stick a needle in a nose, I'll stick a needle in a cheek. This should be okay. And I guess it's kind of funny. I was never an artist really, but I have, I kind of have some confidence in terms of what I think is aesthetically appealing and attractive and how to get there. and that's been helpful.
Yeah.
Not that I'm like not it's not exceptional, but I think it's something that I have some sense of that, and I think that's been helpful as well.
But Picasso said that as well, didn't he?
You're in good company.
Yeah, really, exactly.
So you made a statement a second ago saying what could go wrong, and I know that you'd probably be a little bit facetious in some respect, but I mean you've got a surgical background, and you obviously got a very acute understanding of the way the anatomy works. You're sticking a gel into someone's face, so we're going to get onto this further on in the discussion, but the concept of a vascular occlusion from someone like yourself with a deep surgical background, had that concept or that complication or possibility of that complication ever crossed your mind?
Crossed nobody's mind we were happily jabbing needles into every possible place for, I don't know, a good decade before it ever occurred to anybody that something may, that we can possibly getting a bunch of stuff into a vessel could be problematic. As far as I know, I had not seen anything like that in literature about dangers. I think I mean and it's just it kind of, I guess I think we've made so many strides in terms of anatomical knowledge, and then in terms of now we're really making strides as well in terms of the actual physiological understanding of what happens with fillers when they're underneath in the tissues, within, whether they're within vessels or whether or not. I think it's really accelerated our just appreciation of what could go right and what could go wrong. And I think it's interesting because I mean, I know we're going to transition into really talking about this in detail, but I think it's interesting and it's difficult because these adverse events don't happen very often. So it's really difficult to have real good scientific data on what the optimal maneuvers are, what to do, what not to do, because it's tough to collect good data on it.
Yeah, I've often wondered whether, I mean, maybe you're the outlier where you're jabbing it everywhere. But when I started, which is 2008, like David said, I did nasolabial fold and lip. That's all I did. And, we didn't have cannulas back then. And we were taught basically one way of doing it. And if you translate that to most injectors doing something like that, they weren't going deep, they weren't doing cheek, they weren't doing temple, they weren't doing jawline. And so some of the scarier areas, apart from, you could argue nasolabial fold's quite scary, but maybe we sort of mitigated that risk by not going elsewhere. And then we got cannulas. And by the way, we only had one filler at the time, which was Restylane. So just the probability was limited by what we were doing and the amount of gel we had. And then things have sort of got exponentially scarier, but also in some ways safer, in some ways not. It's sort of, well, we'll get on to what do we even mean by safe? I don't know anymore.
We know there are
hard to say, but it's certainly gotten a lot more effective.
Yes.
Because in all these discussions, and that's something that I wanted to stress within our conversation as well, is I just got back from the CMAC meeting in London, where it's really a meeting that's really very specifically concentrated on complications and managing complications and preventing complications and talking about what the latest ideas and latest research is. And I think it's really interesting. But I think it's a somewhat limited conversation if you don't bring in efficacy as well.
Yeah.
Because the safest thing you could possibly do is not to inject, right? And I mean, and that's an efficacy of 0, but somehow there has to be some sort of, equilibrium between how effective we are and what the results that we're getting versus, the safety of the techniques that we're using. And I think it's an interesting kind of thing to think about. Do we have what are the optimal safety techniques, but also how are those safety techniques affecting our efficacy? Are they taking away from the precision of our results? Are they taking away from what we can do with fillers? And I think that's I think it's part of the equation.
Yeah, such a good point. I spoke at CMAC last year, albeit virtually. I didn't go to London, and you wonder a new injector who attends that, it's an amazing conference, like such good speakers and topics, and some things are touched on in great detail, but you almost wonder if the focus is so scary for people that they come away thinking it's more common than it really is. And I don't mean that in a way that sounds blasé. I just mean, thank God some of these things are pretty rare, right? Particularly blindness, stroke, and
for sure,
some of those terrible things.
Your point is very well taken. I absolutely agree with you. Sometimes I'm sitting in the audience and I'm hearing some of these guys, I'm seeing these people present, and they're putting up horrific slides, and I'm having second thoughts.
Yeah, exactly. But, I think we've discussed it on the podcast before. Every conference you go to, doesn't matter which one you go, Monaco, IMCAS, wherever, there's always a talk on blindness, the current evidence to treat it, and maybe vascular occlusion and now ultrasound. And it's almost like when you're a doctor or a nurse, every year you do your advanced life support or your basic life support. You just remind yourself of these protocols, no matter how many times you've done it. You just you go through the motions and you learn it again and you look at the new evidence. So I think it's important to always revisit these things, and hopefully if anyone's listening to this, we at least make you think. I don't know if we've got any answers, but we make you think about what you're doing next time you've got a needle in someone's face.
Yeah, like doing a driver safety course every 12 months. I mean, because everyone hops in a motor vehicle on a daily basis, or hops in some sort of transport, plane or train or bus, whatever it is, and the risk of a fatality or serious injury on the road is far greater than probably getting a blindness result from a filler. But for some reason,
for sure,
I mean, I think we just, as human beings, we're drawn to negativity and scary things. It's a bit of a survival mechanism, I think, that's built into us as human beings. So
So enough teasing the listeners. Let's get into the topic of the day. So this all kicked off on, I think it was 19th of September, with our friend Professor Sebastian Cotofana. He did a post discussing a paper that he was a co-author of, and the title was, "Is Constant Needle Motion During Soft Tissue Filler Injections a Safer Procedure? A theoretical mathematical model for evaluating patient safety." And as always, he gets a lot of eyes on his feed, and there's, all the big players are sort of looking at what he's doing, and you got a lot of comments, both pro and against, and people arguing. And I put a comment and, got quite a few people supporting it, but I don't want the support. I just want to stimulate the debate. And then kindly Dr. Rivkin said, I'll come on your podcast and we'll talk about it. So here we are. So we're going to talk about, I guess, the paper first of all, and what it, I guess, implied, and then maybe just some high-level thoughts on some of these techniques and safety maneuvers, and see what we come up with, I guess. So I don't know if you said you got the paper up there, Alex. Did you want to, I don't know if you can summarize it, or I've got a few notes here as well.
Sure. I think it's basically it's a theoretical study. It's a paper about a theoretical kind of model of injection, and a mathematical model of injection, he sets up the injection he sets up the model in such a way that the needle is going in as like a cone through one piercing, like it's pierced down, and then it goes into a cone all around as a model of needle motion.
Yes.
And then they do this mathematical modeling stuff, and the conclusion they come out with is that the more you move the needle, the more chance you have to encounter a blood vessel.
Yes. Which, I mean, logically it seems pretty obvious, right? You move the needle around more, you're going to find more stuff.
And then, so here, I can read you guys the conclusion. I can read the conclusion for your audience. It's a one-paragraph thing. And I think that, and the problem with it, and I think that it's nice to have this conversation. I think it's interesting to stimulate the conversation.
Yeah.
But the problem with it is, of course, in these kinds of arguments about aspirating movement and stuff like that, which are active debates, people latch onto any bit of evidence that they can to support their own side. And so people latched onto this and say, Dr. Cotofano, thank you so much for doing the research that finally proves beyond a shadow of a doubt that I am right and that you shouldn't move the needle, right?
This confirmation bias, right?
Right.
Yeah.
And this is what all over these comments on Instagram, I'm just like, I'm clutching my head thinking, what are you guys talking about?
Yeah.
So here's the conclusion. The results of this theoretical mathematical modeling study revealed that the constant needle motion technique covers a soft tissue area shaped like a cone, that nobody injects like that I know. And that this soft tissue volume increases with every performed injection pass. The number of performed injection passes increases the probability to encounter an artery within the subdermal soft tissue volume covered by the needle, and that the probability of injecting any volume greater than 0, and this is the important part, the probability of injecting any volume greater than 0 increases with the number of performed injection passes. We therefore conclude that the constant needle motion technique does not increase safety, but rather may increase the odds of causing intra-arterial product administration. So, in order to form that conclusion, you have to make the assumption that any amount of filler in a vessel has an equal chance of causing a vascular occlusion.
Yes, and we don't have a figure for that. I've tried asking 100 people today and looking up some papers, and I got some numbers. For example, if you inject, I don't know why you would, but if you're injecting in or around the supratrochlear artery or the glabella, they speculate that 0.04 mils of filler would be enough to, cause a retinal occlusion. Fair enough. You're near the eye, it's a small caliber vessel, but I personally don't inject glabellas. It's the only place I don't inject with filler. But nevertheless, that number doesn't translate to, say, if you're doing a chin or jawline or lateral cheek or other things. So we don't have a number.
But even so, you'd have, again, non-medical brain, just trying to use logic. There are so many variable factors. What's your extrusion force? What size needle are you using? Like, what's the G prime of the product? All these types of factors that you could, you'd need like some sort of Turing test. You'd need some sort of machine to be able to calculate the infinite possibilities.
That's a good point. Actually, so in this mathematical modelling, and by the way, the lead author was someone called Ivan Gonchar, who's a mathematician. He's not an injector, but, fair enough. And I have to admit, when I read the paper, I didn't understand any of the maths. It was like watching, Stephen Hawking's kind of stuff. Yeah.
But you don't.
Yeah, you just read the occlusion. The conclusion. Jesus. But what they said was, I'll just explain it again because there's a bit of a weird thing that they did, I think. So like you said, there's one entry point, and then they sort of focus on, you were filling a cone shape of filler, like down to the bone, in sort of
like a bolus kind of thing? Were they doing?
No, so they're doing in and out fans, and the important thing that you touched on is the same speed of moving the needle in different directions, and the same extrusion force, whatever depth you're at.
Yeah.
So they weren't doing a bolus, almost just doing threads everywhere in a...
But it's not a fan like you usually do a fan, which is like this.
No, it's down in the layers.
Down, and then like that, which is like, I don't know anybody, like people don't usually do that. So it's kind of strange.
I've seen injectors, for example, when they're doing a chin, they'll do a bolus down on the bone, and then without stopping injecting, they'll come more superficial to create like a cherry on top. Even Arthur Swift does his sort of double ice cream scoop thing on the zygoma eminence. So not saying everyone does this commonly, but I have seen it done. So it's not completely weird, but it's certainly not the norm. And they certainly don't do it in, multiple passes. They might just do one sort of path of the needle. But yeah, so I don't know if you want to sort of critique it further. You're basically saying it's an unrealistic injectable technique. And I guess the other assumption is, you're the surgeon or facial surgeon. There's a big assumption that all of the vessels are everywhere, rather than being in a particular plane, or larger caliber ones, deeper and more superficial. They get smaller. Obviously, you get more capillary plexuses. So it doesn't really take.
I actually agree with. I actually agree with that part. I will happily concede, because I think also that the face is one big blood vessel, and as a safety goal. The goal of not getting into blood vessels, I think overall is naive.
Correct.
I think we're in and out of blood vessels all the time.
Yeah.
And we inject so much all over the world, and we're in and out of blood vessels so much all the time that to say that amount doesn't matter is unrealistic. It's just not. It's not in this reality. It doesn't make any sense.
Yeah.
Yeah.
So
we only know about the occlusions that result in a visible adverse. Like there's probably occlusions that happen all the time that are of no consequence because the body deals with it. Yeah,
that's what I left on the comment on the original post. I said, look, the reality is we're in and out of vessels all the time. We bruise people all the time, which is confirmation that you've been in a vessel and you've fucked it up, but you didn't get a vascular occlusion, or at least a visible bad one. We would probably get microemboli in these tiny vessels, and who cares? It gets supported by that capillary plexus or that arterial plexus. But what is the point of the paper if it's so unrealistic? I guess is my question.
So, right, and then the question is, and then I mean, and it's okay. One can write a paper with limitations in the paper and say, okay, look, this is just a mathematical model. There's limitations on what this can say, but here's the somewhat limited conclusions that I can give. That was not the strategy here. That was not the way this paper went, because it says very confidently, we therefore conclude the constant needle motion technique does not increase safety, rather may increase the odds of causing intra-arterial product administration. Compared to what?
Yeah.
They don't say.
Yeah, I have to say I did
compared
actually.
To not injecting, yes. Compared to not injecting, it definitely does.
I left Sebastian a voice note yesterday just to say, we're going to do this podcast. Do you have anything to sort of add or whatever? And he said, hi. It's kind of funny. I was wondering how these needle movers also combine it with aspiration, because there is one or two people out there suggesting do both at the same time.
That makes no sense.
How many hands?
I fully agree with you, but. Yeah, I don't want to throw people under the bus here because, I'm not going to sit here and say I'm right and they're wrong, but there's someone who's been on our podcast who advocates it.
How would you actually even physically do that? Moving a needle. It's difficult enough. I've watched it done. It looks difficult to do even stationary.
Yeah. I mean, it seems a bit silly to me, but nevertheless, it's been proposed as rather than aspirating or moving, it's been proposed as sort of a third way of doing it.
And then this may be a good segue to talk about what is aspiration in that case.
Correct. Yeah. So, let's get cut to the chase. What are you, an aspirator or a non-aspirator?
I'm definitely a non-aspirator.
Okay, fine. So that sets the scene for this conversation. But okay, so what is your sort of, I guess, for a listener who's just started injecting, maybe haven't even heard of it, what is it and why do we do it, or why are we traditionally taught it?
By the way, I think 50% of people either switched off or turned the volume right up now.
At this point, yeah, I know. Well, this is the thing. Okay, so I've been trying to make it make sense for a long time in my head, and I have been sadly, I've been unsuccessful at that. So aspiration, very simply, you put a needle into where you want to inject. If you're using a needle. Now with cannulas, it's a different kind of story. But with aspiration, you put a needle where you want to inject, and then you pull back on that needle. If you get blood, you're in a vessel. It's a test. It's essentially a test of where that tip of the needle is at a given point in time. Yeah. Right? At a given space. So you pull back. If you get blood, you're in a bad place. You move, you take it out, you put it back in, you test. Okay, I don't see blood. I'm not in a vessel. It's safe for me to inject. Yeah, that's basic aspiration. So that's aspiration. I got a question because I don't know the answer to this. Some people prime their needle, meaning they push a little bit down on the plunger to fill the needle hub with a bit of filler. So there's a column from the needle tip into the syringe of filler. There's no air in the needle, basically. What's your understanding of why you would or wouldn't do that, even though you don't aspirate? I don't think it matters. I don't think it makes sense either way. But maybe it makes it easier to detect blood. I think they've tried it on in vitro, and they've seen that if you prime, I forget if it's primed or if it's unprimed. One way, it's easier to draw up for the blood to come back, to have a true positive. But then, because what you don't want, what you really don't want, is a false negative.
Yes.
Right. You don't want to pull back, get nothing, and be actually inside a vessel. So it's I think it's either primed or unprimed. It sometimes takes, you have to hold that aspiration, hold the pressure for a few seconds. Some studies say 2 seconds. Some studies say 10 seconds or 15 seconds. Anyways, but the point being is that if you're in soft tissue, and I'm happy to prove this with ultrasound, which I've tried this with ultrasound a few times. If you are in soft tissue and you are aspirating any of the fillers that we have available to us, Juvederm, Restylane, Belotero, it doesn't matter what it is. With the syringes, with the 1 cc syringes that we have, it is physically impossible to not move. And that's the other thing. As surgeons, we know what it means to hold still, right? We know what it means to really actually not move. I mean, I've in the process of doing neck dissections, I've placed a scalpel on the internal jugular vein. I know, I know what it means to be steady and how much effort it takes and how easy it is to move. So it is, if you're in soft tissue and you're aspirating, that's to my mind. And I want to be blunt because I really think this is true. And I don't want people to be doing things that with having a false sense of security. So I'm going to be blunt about this, which is that I think that if you're aspirating in soft tissue, you are performing a religious maneuver. You're performing you're crossing yourself. You're doing something religious because it doesn't have, you can't stay still. And the face, and if you're doing it in the butt, it's a different story because these vessels that you're trying to miss are large vessels. So if you move a millimeter, it doesn't matter. It's still a good test. The face is a different story, 1 millimeter, and that's the difference between being in or out of vessel.
So wouldn't the counter argument that to be, I've been a junior doctor, you've been a junior doctor at some point. We cannulate vessels all the time to take blood, and you're shaking because you're nervous, and you still get the blood, and you're in, and you can do it.
These are big vessels. I mean, to compare something like a radial vessel to even a angular. I mean, I don't know. I think but I mean, I don't know. I mean, I think we're talking about not. The point being is that they would say that you're not trying to avoid just the huge vessels. They're saying you're trying to avoid any vessels.
Yeah, I mean, this is where I think there are some caveats to aspiration. And to be honest, I'm still not quite sure where I am. I used to aspirate all the time. Then I've read all the papers. I've tried different techniques. I'm now employing ultrasounds. I'm kind of doing a smorgasbord of everything now, to be honest. But I'm trying to rationalize in my head, why would I aspirate on everywhere? That doesn't make sense to me. For example, if I'm doing a lip with a needle, I'm not going to aspirate because I'm moving and changing my angle and I'm at a different depth and so on. And I don't think anyone argues with that you don't aspirate when you do a lip with a needle. And yet it's the same premise, really. But I think most people who are big, proponents of aspiration, they're down on a fixed point on bone. It could be temple, piriform fossa, lateral cheek. And then I think there's a bit of an argument that if you accept that it's possible, because it is, you can get a positive aspiration, then, well, what caveats can you do to make that an even better test? And a simple one would be, well, rather than having your needle 90 degrees perpendicular on the bone, where some of that bevel is clearly in the tissues and not down on the bone, maybe you could have the bevel flat on the bone so it's not, sticking upwards, if you like. And if you did it, say, in temple, you're more likely to encounter a larger caliber vessel. You're looking at sort of anterior deep temporal artery and posterior deep temporal artery. Well, it makes more sense to me to try it there than, say, somewhere more superficial where it's kind of less scary. I don't know. Maybe I'm just trying to rationalize this whole religious thing that you just said.
I mean, I think that what you're saying makes sense. And according to what I did with ultrasound, where I basically tried to make people not move. And I was doing it with Kian Karimi, who is very experienced. I mean, he's not a novice injector. I'm like, okay, dude, don't move. Here's what we're going to do. So when we did it at the on bone, he was successful in really not moving very much. But in soft tissue, it was completely
you would have to be on a fixed point.
Yeah. So I think that is possible. But think of my argument, my issue with that is twofold. And I wrote an op-ed about this in the I forget what JDD or something like that. My issue with that is twofold. Number one, if you're going to do that, then this is where efficacy, I think, comes into play, because then you're limited. I think that if you do that and then you move, that doesn't make any sense.
Yeah,
because either you move or you aspirate.
Agree. Yeah,
you're making a choice. You got to be in one camp or the other.
Yeah.
So if you're going to aspirate, then you're putting a bolus into that one spot, and you're limited to one plane. So how you're elevating tissue or how you're doing what you're doing in the aesthetic effect is limited to an injection in one deep plane, and that's it. Now, I don't love that, because how I do all my injections is I'll go down to, pretty much the bone to a depth, and then I'll raise columns. I find that to be very precise. So I'll inject as I come out, and as I come out, I'm putting filler into all the different planes of the tissue. So, I'm placing filler both superficially and deep, and therefore I open up the various planes of the tissue, and therefore get a lift to tissue, maximal lift and minimal spread. Because if you're maxing out one plane, right, the tissue rises up to a certain point.
Yeah.
And then there's a certain amount of surface tension. And then the filler, after a certain point, the filler goes sideways. So I'm trying to prevent that.
Yeah.
You know what I mean? So it's just kind of, I think you're limited I'd rather be in multiple planes than one plane in terms of efficacy.
I was going to say, it sort of depends on what you want to do, and I'm guessing where you are on the face. For example, if you wanted an augmented, chiseled cheekbone, that makes logical sense. You do, deep plane and superficial plane. But some people would argue that if you stay in the deep plane, it kind of looks aesthetically better because when you smile, it doesn't bunch. And, there's arguments either way.
That's agreed. I think that's true. And I actually do like to stay in the deeper portion. I don't like to come all the way out in the cheek for that reason. So I think that's true. But I think that I like to have, one of the reasons that I move is I think it's a superior move. I think it's a superior safety technique, but also it's, in terms of efficacy, I think gives me options, right? It gives me, so I have more possibilities of what I can do aesthetically if I can move the needle. But the other thing is that, as an ex-Soviet, I tend to be pessimistic about most things in life. And so, because, this is how our history does kind of point to that, to some pessimism. And so I'm more comfortable assuming that I'm always in a blood vessel, that I'm always piercing a blood vessel, I'm always intraluminal, and therefore that I am putting small amounts in at any given point in time because I'm always moving. And therefore, I'm never relying on any one thing, which worries me, because I know that if I put small amounts into blood vessels, I'll be okay, because I've been doing it for 20 years. And I know that these microemboli, as we were discussing, won't cause that kind of vascular occlusion that can be, catastrophic in terms of ischemia and necrosis, stuff like that. I know that a bolus in the wrong place and at the wrong pressure can cause an issue.
Yeah.
Am I so confident in any given technique, aspiration or anything else, that I'm going to be placing a bolus? I'm not. I'm just pessimistic that way.
Yeah.
I want to be,
Going back to sort of aspiration, you said you've got to be stable, and yet in your experience, many people aren't stable. And I agree, I train injectors and you see it. And, even I get an essential tremor sometimes. It's normal, we're humans. But, the proponents of aspiration will say, well, look, I've demonstrated on stage that I've had a positive aspiration, therefore it does work. And so, how do you counter that? How do you,
Again, I assume I'm always in blood vessels. I assume that the assumption though there is that, I've encountered I have a positive aspiration. Thank God I didn't put filler into that spot.
Yeah.
My answer to that is, thank God that you didn't put a bolus of filler into that spot or any other spot.
Yeah.
Because the next negative aspiration that you do before you put a bolus in could be a false negative.
Yeah.
I don't know.
I guess.
So it's just.
Going back to your technique, which is, it's perfectly valid. I guess the question is, do we need to do boluses? Can we get away from doing boluses? Because if we could, then we could sort of get rid of aspiration as a technique because it's only used for boluses.
I think we should. I don't think there's any reason to do boluses ever. I don't know. I never do boluses.
Yeah. Trying to think the place I would commonly do it would be lateral cheek, but I can alternatively go with a cannula subs mass and sort of do a similar thing, moving my needle or moving my cannula.
Absolutely.
On the same plane.
Going like that and do a stripe coming out.
Yeah. I just think it depends on what you're trying to achieve with this setting. And it goes back to your balance of, well, if we're super duper safe, we just don't inject. And if we inject so creatively that we don't take safety into account, then that's also wrong. So I think it goes back to your equation.
Do you think that when people get a negative aspiration that they will then potentially inject with impunity or no fear? And then if the answer to that question is yes, then the next point that I would sort of raise is, well, what other factors increase the risk of an occlusion? Does how fast you inject increase the risk? And so if you've got a negative aspiration, and especially this is for like maybe young, inexperienced injectors who have just taken this as dogma and gone, right, as long as I get a negative aspiration, I'm good to go. Yeah. And then inject and all the other potential safety protocols go out the window and they end up with a problem. Is that a factor? Or?
I'll let Alex answer, but that is the big criticism aspiration. It implies it's a very black and white, safety mechanism. And sure, if you get a negative aspiration and you don't get an occlusion, then hey, it worked. But if you do, then how do you sort of counter for that? You can't. You only know after the event. What are your thoughts on that?
I think that if don't get me wrong, it's an effective test. But if 900, I inject a lot of people. You inject a lot of people. It's out of 1,000 people, 999, everything's okay. But that one person is a career-ending event. That's just from our standpoint. It's also a devastating event from them.
Yeah.
If it's a visual complication, I think that I get worried when people do something like that, and then they're like, "Oh, I had a negative aspiration, so I can do whatever I want. I can just slam a bolus in there." And pressure matters. How much pressure you're putting on the plunger, I think really matters a lot. If you're overcoming blood, it's just, and we're still working. I think we're still working out what actually happens when filler gets intravascular. Does it proceed as a plug? Does it shatter immediately into a shower of microemboli? I think the latter, most likely, because that explains why it is. The plug theory doesn't make sense to me, because we take vessels all the time in surgery and we don't have an issue because of collateral flow, collateral connections. So I think if you're plugging up a vessel, there's enough collateral flow within the face that it shouldn't cause the kind of vascular occlusions that we're seeing with ischemia and necrosis, and also blindness, but ischemia and necrosis. The only thing that makes sense to me is that when you're intravascular, that filler shatters immediately into a bunch of microemboli, and if you put a lot of it, an entire whatchamacallit, derma. Oh my god, now I'm blanking on the name. What's it called when the vessel, the area of tissue that a vessel supplies?
Oh, an angiosome. An angiosome.
Angiosome.
Yeah.
Thank you very much. So yeah, I mean, I think that's what really happens. That's what that's what makes sense.
Yeah.
So but I worry about that. I really worry about new injectors feeling that they have a license to do whatever they want as long as their aspiration is negative.
What do you feel about this concept? And again, I'm not proposing this. I was just thinking as I was planning some of these questions. You get a new injector who knows nothing about nothing. And to be honest, their main concern is just getting a result right and getting it in the right place. They know they get so tunnel visioned on the result that everything else kind of doesn't matter when you're that new, or at least that's how I thought when I was a beginner. But if you introduce a concept like aspiration at that stage, as long as you tell them all these caveats, like this isn't 100% safe, and there are other things you can do. However, this is a quick and easy first sort of line of defense that many people are doing, but do some reading and we'll teach you maybe a moving technique next time you come for another lesson. It's sort of teaching people one way but not the only way. What do you think of of graded teaching of these safety techniques?
Well, I mean, I think performing an aspiration correctly is a very much of an advanced technique. That's a hard thing to do technically. I think it's I mean, again, I'm a little bit biased, but I think that movement is a much easier technique to teach. And it's when I go out there and I teach for, about injection technique, I don't hesitate to teach it to beginning injectors, because they get it very quickly.
Yeah.
And if they can I teach them speed, I teach them pressure, and I teach them to move, to always slow. I physically put my hand on their hand.
Yeah.
And to slow them down. And I say, talk to them about nice steady motion, soft pressure on the plunger. And they get it within one training. They can get that whole thing. Teaching them how to do a proper aspiration, I don't know. I think that's a little more difficult. And I don't know. I just think that it's.
I guess if you don't agree with the principle, you probably wouldn't teach it at all, is what you're trying to say.
I wouldn't teach it. Yeah. I just think it's safer. I think it's safer to move.
Okay.
I think that it's the. I don't know. I would get worried. I would get worried that I teach again. Okay, so here's my thought process. Here's my real thought process, right? So here's a beginning injector. They don't know. They don't know shit about shit, right?
Yeah.
They don't know anything. And I teach them how to aspirate. I'm like, okay, let's start with this safety technique, and maybe we'll go on with we'll go on to something else later on. They kind of perform it, and it's pretty good, and you're like, okay, but then they go off and into the wilderness, right? And they do do injections, they do their thing, and they forget little things about what they learned during that training, and they start to imperfectly performing that procedure, and then suddenly they're slamming boluses thinking that they're safe. I don't want anybody that I train to think that they're ever safe, under any circumstances, anatomically or with any kind of with procedures.
Fair. You've had a bit of filler in your face. And so as a patient, joking aside, what do you feel more comfortable with? Because you've heard this argument a million times.
What, to aspirate or non-aspirate?
Well, on yourself.
Probably feel more comfortable if the needle was moving.
Okay.
Yeah, I think so.
Fair enough.
Because I just think that
it's uncomfortable, right? Because they're like kind of going back and forth, and you're like, oh man, what's this person doing?
I don't know. And people have got different levels of coordination. I mean, it's just like anything else. I mean, that sort of movement and coordination was not something you're just going to get overnight. That's something that takes and people have got different levels of coordination and sort of mechanical aptitude. So I think you've got some variability there. It will be interesting one day to see, and maybe this has happened when this sort of situation occurs and then sort of goes to some sort of court of law with some sort of damages claim, and the question's going to be, what safety measures did you take? And people are going to come back with a response of they either aspirated or they didn't. And then, the way these things are normally decided is it'll then go to, expert opinions, and people will say, did you aspirate? Did you not aspirate? And it's going to be very interesting to see how the court interprets something like that.
I think it has happened here in Australia with the recent blindness.
Right, okay. So you've got, just as many experts who'll say you should, and then as shouldn't. And then so Where does this all sort of end up?
Yeah, sorry, I didn't mean it's gone to court. I don't actually know, but I heard that the aspirator had claimed I did aspirate.
Yes.
So hence it was brought up in conversation.
Right, okay.
So,
Yeah.
anyways.
I think that's the reason. But I think that's the reason why people are getting ultrasound, by the way.
Yeah, well, I think so, because that'll be the first question.
Well,
Yeah.
I was going to leave ultrasound almost for like not a conclusion, because maybe it's sort of the new gold standard, perhaps. I don't know. I'll just dangle that out there. But we haven't really qualified what we mean by moving the needle, because we've said that the thing proposed in this mathematical model is very unrealistic and no one does that. And yet the title of the paper is moving the needle.
Yeah.
So what do we mean, and what techniques can we do?
If we want to move them. Okay. So for me, the principle is very simple. If filler is going through my needle is in motion.
Yep.
Always. And so whether it's superficial or whether it's deep, going to superficial, or whether it's deep, staying deep, it's always in motion no matter what. I just assume there's vessels all over the place.
Okay.
But I inject small amounts. I inject under low pressure, and I'm slow, and I'm soft, and I'm careful. And I always take my time. I do all of my fast, all my fast motions happen before the needle hits the skin.
Yeah.
When the needle hits the skin, time stops.
Yeah.
You know? And I think I think people get in trouble when they're in a hurry.
Yeah.
Did you ever come across the paper? It was by an Australian sort of group. We know half of them, and many of them been on the podcast, by Professor Greg Goodman. It was called Aspiration Before Tissue Filler, an exercise in futility and unsafe practice. Have you read that one?
I've quoted that paper several times in the papers that I've written.
Okay.
And especially in the op-ed that I wrote, I've quoted that paper a couple of times.
Yeah.
I think that was a very good paper. I very much agree with that group. I'm part of that group.
Okay.
So Mike Clegg was just at the London conference.
Yeah.
Yes.
And he is a great example of Aussie talent. I have to tell you guys, he is a great representation for Australia.
Yeah, he's been around for a long time, Mr. Mikey.
100%.
I was just going to ask, where does the concept of spasm fit into all of this? Because we've had people on the podcast talking before about, is it filler in the tissue? Is the vessel actually spasming? And where does this, protocol, move needle, not move needle, fit into that phenomenon?
I'm going to let Alex take that one.
I think it's a very interesting question. It goes to our evolving understanding of what is actually happening when we get these kinds of ischemia and necrosis events. I think vasospasm is certainly a big factor here, and because first of all, hyaluronic acid filler in vessels causes vasospasm. It's an irritant. Outside of vessels is an irritant, and inside of vessels is an irritant. And so the thing is, when I inject the nose at a time. So every day I'm injecting noses, and every day I'm injecting noses that have had surgery, because I inject post-surgical noses all the time, which is something that not many people do. And when I do inject these post-surgical noses, I see ischemia and necrosis. Well, I see ischemia. I don't let it progress to necrosis because I manage it. But I see it quite frequently. Probably because of some of the compartment effect of, with these patients that have already traumatized tissues and traumatized skin with scar tissue. But I find that when I treat with massage and heat, it really resolves almost everything in terms of these. Because I see it blanch, I see the blood capillary refill, not very good. I see it start to model a little bit. I consider those two maneuvers to be mostly antispasmodic maneuvers. And so when I do that, so I think that spasm is a big factor here. And I think we're still working it out. You know what I think was really going to make all this kind of stuff, all this discussion completely moot? Smart needles.
Yeah.
When we can have a needle that buzzes when you're inside a blood vessel or a major blood vessel, that'll be great. But, we're still waiting.
But I think, like you said, we're probably in them all the time. It might be tiny ones.
No one will inject anymore.
Yeah, it'll just be bzz, bzz, bzz.
Feel like that game. You remember that game of Operation when you were a kid?
Exactly. But yeah, I mean, I think, I thought you came up with an idea one day for something like, it was ultrasound, which we already have, but it was almost like a 3D game where you could also like watch it go down, almost like virtual reality, and see where your needle is. That maybe that will come one day. I don't know. Who knows?
I think it will. I think it has to, because right now ultrasound there's a learning curve. There's a fairly steep learning curve.
It's like learning a language.
It's not easy to do.
Yeah. I sort of forgot to carry on with why I mentioned that paper by Goodman et al. was because they propose a number of really simple things. So if you go down on a bone and you want to do a bolus, you can do your bolus, but do what they call micro movements, where you might sort of walk around in a little circle, move a few millimeters here and there. So you sort of build a bolus with small boluses, I guess. So you're constantly moving, but still kind of doing what you wanted to do. So that's one of the things. And you touched on the other ones, David. Small extrusion force, small volumes. So I think they say a bolus of no more than 0.1. You can argue this till the cows come home, whether you're pro, against, aspirator, not aspirator. There's evidence for all of this, I think, truly.
Not great evidence, unfortunately, because it's hard to make a study about that, It's rare, these events.
Do you know Jubilant Julie? We've had her on the podcast recently. You must know Julie. She, I'm sure it was Julie. She told us that she did some experiments where she basically aspirated her own arm. And just to prove you can do it, it's possible. And I guess, going back to cannulation and taking blood, we all know that you can do it. But
for sure.
Does it change when you're trying to take it through a column of filler? Well, maybe. It just depends on how hard you pull and how big the vessel is, I guess, and what's the pressure of the vessel. So I don't know. I think you can have evidence for all things if you want it to.
For sure. No, that's very true.
But we've got to balance it against the aesthetic effect, like you said. All right, so tell us about ultrasound then. How's your sort of career learning, and who did you learn from, and what are you actually doing with it?
You caught me there. Nowhere. The answer is nowhere. I don't have ultrasound.
Okay.
But I'm finding myself more and more the lone person, the lone non-ultrasounder. I think it's an interesting idea. I think it's certainly something that some people do. I think there's a learning curve to it. I think certainly some people who are very, very good at it are like Stella, like Leone, are doing injections under ultrasound, like primary injections. They all do all their injections under ultrasound.
Yeah.
I think that's great. I think that for me, it would be difficult. I mean, it would certainly slow me down quite a bit.
Yeah.
At least at the beginning, it certainly would. I think pre-procedure mapping with ultrasound doesn't make that much sense to me, because you're querying a three-dimensional block of tissue for vessels that have a course that can go in any XYZ direction, and you're doing it. You're kind of flattening out into two dimensions because you're watching it on a screen. I think it's difficult to make conclusions about that as mapping. However, as for complication management, so injecting hyaluronidase into exactly the right place where there's flow issues, I think it's very useful for that. I haven't gotten around to getting it yet. But I think it's I think that makes complete sense.
So can I ask then, how do you do a temple and how do you do a piriform fossa? What's your sort of technique?
Take my needle and jab it in
Shove
there
it
and move out. Yeah. Well, I go directly in. So I'll take a needle that is, the smallest I can get, which is usually 27 gauge because in these areas are fairly deep and I want to have a robust filler.
Yeah.
So whether I'm using something that's like Volux or something that's like, Voluma or, Restylane Lift, that kind of thing, I'll put it in and then go down to bone and then inject as I come out, watching the skin, but making sure that column is about 0.1 cc's, not more than that. And then making multiple columns.
Okay, so
same thing with the temples.
So here's my rationale for how I think about ultrasound, because I'm not going to sit here and say I'm an expert. I'm certainly not. We've had Stella and Leonie on the podcast, and they are the gurus. But I'm using it for one or two particular things, and one is piriform fossa, and I don't even do gunshot on the temple anymore. I've changed as a result of what I've seen on ultrasound. But, we're sitting here arguing about what technique is better. Is it aspiration? Is it moving the needle? And we've said that you could argue either. And yet, when you think about it logically, if we had a magical device that could look in the skin and show us where the biggest, scariest vessels are, which is ultrasound, I can't understand why people wouldn't use it. And I don't mean that as a criticism too. I just mean just a generality. We've been crying for this thing since we started injecting or since we started knowing about occlusions. And now we have a simple method to just have a look. It takes like 10 seconds to just, hover over the piriform fossa and go, oh, okay, it's on the bone. Maybe I'll go more superficial, or vice versa. It's superficial, I'll go on the bone. That's how my caveman brain sort of thinks. I'm not saying it's perfect, but it's sort of an extra thing that if I went to court and God forbid there was a terrible thing, I could say, well, look, I really did this thing and I've got a video showing it.
Well, that's the first thing that an attorney would do on the plaintiff's side, is look for a strategy to make it look like you didn't follow best practice, or you didn't take advantage of what was possible to reduce the chances of this happening. And that's the kind of thing that, people like Jahan, who we've had on the podcast many times, who's a medico-legal lawyer, would do to try and form a case. And so I think when you say, why do people push back on it, I think that the prospect of having to go and learn something like this, because, I've seen the ultrasound. Before cosmetic physicians and nurse injectors started looking at this stuff, it's in the hands of radiologists and sonographers. This is like a specialty almost to understand and interpret what all this stuff means. It looks like just a grey mess on. Looks like your TV's broken. Yeah. It's hard to interpret what it is you're looking at. So I think the prospect of going to have to learn that is something that a lot of people potentially are mentally struggling with to sort of get over that.
I get it, because I've been there, and I haven't had lots of training. I went to Paris and did some stuff with Leonie, Stella and Steve Weiner, and then I did a day course here in Sydney, and I did the online courses that cutaneous facial ultrasound do, which, by the way, we have a discount code for, but we'll talk about that at the end. But, you've got to start somewhere, and I personally think it's kind of lazy and undefendable to say, well, it looks a bit hard, I won't do it. Or it costs $5,000 to buy a scanner, too much. Yeah. And yet you earn $10,000 a day. I get the argument, but I just don't think it's strong enough.
Yeah, I don't know.
Injecting's hard until you do it. So I don't know. I'm not saying ultrasound is the answer, but I have helped a colleague sort an occlusion out by finding the vessels and doing an intraluminal hyalase. So that definitely works, and lots of other people have done that. I've used it to visualize weird and wonderful puffiness that is chronic and on and off, and no one can work out what's going on. And you can see the filler and dissolve it. And touch wood, I've had 3 occlusions in my whole career. None of them were sort of expected, and thank God I managed to sort them all. But I think if you can add on layers to your safety and also make the patient feel more comfortable that you're doing as much as you can, I think it's worth learning.
Yeah.
I don't know. I don't want to sit here and wave the flag and say if you're not doing ultrasound, you're terrible. I'm not saying that. I just feel like have a look, explore it, and try it. And if you like it, then awesome.
Good advice.
Yeah.
I think that's great advice. And there's so many, now it's not a you don't have to search very hard to find learning resources on ultrasound. It's available. It's out there. So I think that's good advice.
I was going to ask you a question just quickly on ultrasound, specifically to you, Jake, was when filler's been there, not so much in an emergency case, but if you're dissolving something, so a patient comes to you maybe from someone else and they've got some issues. Like I know someone that had a patient the other day, they had cheek implants, they had some Aquamid in there, they had some HA, and this injector's looking and they're going, I can't, like this filler's now so integrated into the tissue, I don't even know what I'm looking at anymore. Have you experienced that? How do you sort of...
So, I mean, that's a complicated case, obviously, but I actually think the word integration is absolute nonsense.
Okay, so
it does not become part of you. You know, when I first heard the phrase, I literally imagined filler almost bio-integrating and becoming like flesh. And that's how I imagined it. And then, you know, I'm sure, Alex, you're a surgeon and, you know, maybe you've looked in faces and seen fresh filler pop out a nose, you know, 5 years after it was implanted. It doesn't integrate.
Okay.
I think what we mean by integration is things settle down, the swelling goes, it looks natural, and hey presto, you're happy with the result. But it doesn't do this magic transformation. It's still filler.
Yeah.
So when you look at it on an ultrasound, you see it looks like black blobs.
Okay. So
if it's HA filler.
Because I just thought like the filler doesn't really completely break down. It just loses some structural integrity and maybe breaks into smaller pieces. So you're sort of trying to...
I don't even know if that's true.
Okay.
I'm not sure. You won't have to ask Mobin that.
Yeah, interesting.
But
sorry, side question.
Yeah, look, cheek implants as well. I mean, that makes it difficult.
Yeah.
And in fact, why did they have silicone and implants?
I don't know. This patient was
That's
in
fucked.
the 60s.
I wouldn't touch that.
Well, here's the problem as well, is that apparently they think that the filler that they had was affecting the smile. And yeah, it was complicated. It might have been that the cheek implant is now pressing on a nerve that it wasn't before, or who knows, it could be.
I mean, what Leone has shown is it's seeming more common that if you put filler in the SMAS, which is the muscle layer, which, you know, I guess can inadvertently be done if you sort of don't know what you're doing, that affects, you know, basically myomodulates in a bad way, so you can't smile as well. Or some of your muscle movements are less symmetrical. So, and if you dissolve that, hey presto, you go back to normal. But your case sounds a bit
it's a bit of a nightmare.
Scary. So, Alex, have you actually been given an ultrasound and had a play? Like, have you got to that stage, or?
I played with it with Leone, actually. She was here, and so I went over to an office, and we did a few hours, and it was interesting. So I'm kind of starting to do research about what devices and what, you know, how the resolution is and all that kind of stuff. So
again, if there's anyone listening totally confused, I don't think you can go wrong. You know, go to Claris or go to Vino or whoever your local provider is, and before committing, just have a play. Go to their workshop or wherever they go, and, you know, don't get too fussed about which is the best device. Just start with something simple that's affordable, that works. You know, it's like buying a car. You're not going to buy a Lamborghini for your first car. So same for ultrasound, right? I don't know. I think people overthink these things. Just start. Just do something and have a play, and go from there. So how do we sort of summarize this? Because we've sort of said that there's evidence for everything and no one knows really, and there's all this conflicting data. So if you had some money and could design a study or produce some more evidence, what do you think we still need?
So much. So much. I mean, it's hard. You know, I was thinking about that, and I don't know that you can design I think that designing a study that's going to resolve the question of whether aspiration or movement is the better technique, I think it's very difficult to do, because people do these studies, in vitro, and they, I took this tubing and, filled it with this and put it under this much pressure, and here's what I did and here's what happened. Yeah. But it's not the same. It's still a model. It's still imperfect. Yeah. And so I think that it's so rare to have these events happening that it's like, and it's, what are you going to do? You're going to take a population that's like aspirators versus non-aspirators. I think it's a tough challenge.
Yeah.
I think the technology is going to solve the issue.
Yeah, 100%. I took the liberty of sort of taking the 9 suggestions from that Aspiration paper by Goodman et al. I thought I'd just read them out, just in case everyone's sort of wondering, well, I'm still confused, what should I do? So key point number 1 was understand the safest depth of injection in any given area. I think that's reasonable. I mean, there's nothing safe about anything, but if you understand what is common and not common, that's a good starting point, I guess. Inject very slowly with a low extrusion force. We've already covered that. Cannulae are considered by many to be safer alternative to needles in certain areas. However, the smaller the gauge the cannula, it may somewhat behave like a needle. So again, nothing is fully safe, but maybe safer. Consider utilizing local anesthetic with adrenaline at cannula entry points and within the injection field to constrict local vessels. Fair enough. Consider directing the needle or cannula perpendicular to the primary axis of the vessels in an anatomical region to reduce the likelihood of vessel cannulation. We didn't really discuss that. What do you think of that?
It's tough to. That's tough to do when you can't see the vessel, right? I mean, how do you know the vessel's going this way, this way? So, I think theoretically, yeah.
Yeah, I guess if we think back to our basic 2D map of, the facial artery kind of does that, go the other way.
Yeah, go the other way.
Yeah. 6, microboluses should be injected in small aliquots, and they suggest under 0.1 mils. I think we covered that. Move the needle in the chosen plane at all times when delivering microboluses, even in small amplitude movements. So I think it's intuitive that even if you were in a vessel, you'd inject less filler.
Yeah.
Consider ensuring the direction of injection is away from the eye in high-risk areas such as nose, glabella, and nasolabial fold. So we wanted to ask you about noses because you do tons of them. I think you agree it's a higher-risk area. So first of all, have you ever had an occlusion anywhere, let alone the nose, but anywhere?
I've only had occlusions in the nose.
Okay.
But what do you mean by occlusion? I think I have occlusions all the time. Like, I think I have occlusions probably once every 2 weeks.
Okay.
But these are minor, because how I inject the nose, I guess, backload or decant filler into those 0.3 cc BD syringes. So the 31 gauge needles are very tiny. And so I'm putting my injection volumes in comparison, we talk about 0.1 cc's, my injection volumes are 0.01, 0.02 cc's when I'm doing those. 0.01,
okay, right.
Max 0.03. So tiny, tiny amounts. So if I do get any kind of issue where with vasospasm or with, if I get intravascular or in the tip, if there's a compartment effect where I'm putting it's so tight that my putting filler in compresses the vessels. It's a small amount and it can be reversed and corrected and not a big deal.
So you do an injection, you notice it's pale or, get a bit of mottling or whatever. What do you do? Because you mentioned heat and massage. So how do you heat it? What do you do?
So first of all, so massage. So literally it's over here. I'll see it, for example, on the tip of the nose. It gets white. It gets, the capillary refill is slow. I start massaging it fairly aggressively. And then if that brings everything back, I go back to injecting. If it doesn't, and if I still see it, the capillary refill is slow, if I'm maybe seeing it the colors start to change to be a little bit darker, slightly, and it's still in the first, few minutes of what's going on, we'll put some heat on the area for a few minutes and see if that resolves things. And those two maneuvers usually resolves, 98% of any kind of issues that I see. If it doesn't, then we proceed to, other things to do. So including, and then I'm thinking, okay, this is something that is more than just a little vasospasm. This may be something that's intravascular, maybe something that I really am having a little bit of a compartment effect. So then we go on to I'll go on to giving somebody aspirin, steroids, oral steroids. I'll give them a Medrol dose pack, which is easy to do. And I will, put some, I put nitro paste. I think I know it's controversial. I don't think it does any harm. I'll put nitro paste on, and then I'll consider whether I want to reverse it or not with hyaluronidase. That's that stage. And then there's further stages of what to do if that doesn't immediately resolve everything.
So how many people have come back with an established either the little vesicles or an actual occlusion, like an ulcer basically on necrotic skin? Have you ever had that?
Early on in my career, I had it a few times when I was using mostly Radius, which is not non-reversible, but really there wasn't much else that lasted any decent amount of time. I had that happen 2 or 3 times and managed it with but it was small areas. We managed it. What did we? I think it was before we were doing hyperbaric oxygen. We didn't know about hyperbaric oxygen at the time. But one person got some a little bit of visible scarring. She'd had like 4 rhinoplasties in the past.
Wow.
And it was, again, it was early in my career. I didn't do her any favors. So that was unfortunate. And then there was a guy where there was a little tiny bit of tissue that went missing from the nostril. And again, we didn't know what to do in this kind of in these situations. Now, with hyperbaric oxygen, with using reversible fillers, that hasn't happened it literally hasn't happened in 12 years. So it's always been something that I've never had a scarring or permanent tissue damage. Sometimes it's taken a while for the skin to come back to normal, but it's never scarred.
Yeah. I mean this in a very respectful way because you're super experienced and ex-ENT surgeon, etc. But you do noses all the time. What gives you the confidence that so it's almost a law of probability, right? That you're in the vessels and you're saying maybe on a weekly basis there's a little sign that you need to do a maneuver to sort of get rid of that filler or do something. So I guess I'm asking, why do you still do it? Particularly for post-op noses where the vascular changes, the scar tissue changes, it's higher risk still. So why do you do it?
Well, I think, it's interesting because everything is relative, right? No matter what I do, whether it's post-surgical noses, whether it's, virgin noses, none of that matches the risks of rhinoplasty surgery.
Yeah.
That's just, we talk about it a lot, and I know that we present about it a lot, of course, at every conference. But the thing is that relatively speaking, we're talking about very low risks and a procedure that is extremely high rewards. These people are facing, these people have noses that are, they're not all of them, of course. Some of them are just want to tweak a couple of things and just want to make things absolutely perfect. But some of them are really pretty disfigured. Their noses look really funky.
Yeah.
And here I have the option in 5 minutes of correcting that nose and making it look perfectly natural, like nobody would take a second look at it. How can I not?
Yeah. I was trying to be a good host there because I don't know why here in Australia the nose is very heavily sort of
it's controversial,
restricted and controversial. I don't know how or why that came about. In many other countries, every man and his dog's doing noses, but here I think there's in some ways a lot more insight that it's a high risk area and many people just don't touch them. I do, but I've stopped doing post-op noses. I don't do anything. I was watching some of your videos online, but I don't go lateral. I don't go into the nostril. I don't try and fill craters from old scars. I just stay on the midline, and I sort of have decided where my lane is. But like you said, high impact, saving people's surgery, life-changing for some people. It's valid, right? But I guess as an injector, you've got to work out, well, what is your skill level and I guess comfort level as well. You want to sleep at night.
Yeah.
Very much so.
I don't think if I saw what you're seeing with, little pale spots every week, I'd give up.
But they come back. And I mean, what concerns me is people that are like, is people that go on Instagram and are like, oh, this is so easy. Look, 1, 2, 3, and it's done. This is great.
Yeah.
I mean, I can do this. And then they see, of course, they see all they don't see the disasters.
Yeah.
And it's good for, most of the time. And like any of these kinds of injections, low risk. But when there's a problem, there's a big problem.
Yeah. Well, thanks for being honest with your complications, because many people aren't, and it's refreshing, but also reassuring for listeners that everyone gets complications, I guess.
Yeah. It's not helpful when people make up things that aren't true or don't talk about the things that go wrong, because that's how we all learn.
We wanted to ask, I mean, you claim the title of basically the inventor of the non-surgical nose job. I'm not sitting here denying it, but what's the history of it? Like, when did you start, and how do you know that?
So I don't know. It's not. I mean, I've said it. I've said it. I shy away from because I don't know that for absolute certainty, because I don't know. Maybe there's somebody in China doing it. Years before me. I have no idea. I just know that when I started doing it in 2003, 2004. Nobody was doing it.
Yeah.
And there's no papers written about it. There was nothing in the literature, because I looked. Yeah. And it's just the first patient came to my clinic and she said, I've done rhinoplasty before. I knew the result that I wanted to achieve to give a straight nose. And I thought, damn, I can do this with filler. This is not that difficult. I can achieve this result.
Yeah.
This seems like a really revolutionary thing to do. And I went into Medline to see where is this? And the first paper I saw was from Webster in 1981 talking about silicone.
Right.
And I'm like, I think I can do better than that. And then the next paper after that was how silicone was a disaster and how there's all these issues with it. So, so I think that, and it's just, and went into the media and it went from there. I was young and I should have published at that time, and I didn't publish until considerably later on. But I was just setting up a practice and trying to get my life in order.
Fair enough. Well, that's been a really interesting chat, and I hopefully everyone's both educated and still confused and curious and all the rest of it. I don't know. I just think it's good to talk about these things and just to make people think. I'm not going to sit here and say we've got the answers. I don't think we do.
No, but fascinating. I mean, as you said, it's a controversial topic, and there's a lot of dogma in the industry, so it's good to have some fleshed out conversations where we can sort of look at the validity and utility of different sort of opinions and techniques and try and find our way forward as an industry.
100%. If you are one of our patrons, I'll put these papers up so you guys can actually read them and see what we mean by cones and all that kind of stuff we were talking about.
And speaking of ultrasound, do you want to remind the listeners on how they can take advantage of our partnered offer?
So we've partnered with Leonie's company, Cutaneous Facial Ultrasound. All of our offers, that's not the only offer, but their offer is on insideaesthetics.com/offers, or just click the link in our podcast description and make use of the discount, because they've got amazing online sort of modules, and I don't know if you've seen them, Alex, but really interesting. And I think that would be my starting point. Don't go and buy a machine, don't even go and get a scanner and look on a face. Do the online modules, because that clears up a lot of the terminology and what's grey, what's black, what's white, and then go and get a machine. So that would be my starting point. Well, thank you again. It'd be nice to meet you one day. Do you go to Monaco? Do you go to IMCAS? All right. Well,
I'm there these days. I'm there every year. So it would be great to grab a drink at Monaco. I'd love it.
Negronis and Monaco. Sounds good. All right. Take care. Well, thank you very much, and we'll speak soon.
Such a pleasure.
Thanks.
Thank you for having me.
Thanks to me. Nice to meet you.
See you later. For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our IA Patreon platform for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.